Let me ask you a very important question. In a hospital, what causes the highest number of preventable patient harm? Is it surgery? ICU complications? No, the answer is medication errors. And that is exactly why NABH has created a complete chapter on medication management. Today, we are going to deeply understand MOM.1, pharmacy services or medication management, not just for theory, but for real hospital implementation and audit readiness. Hello everyone, I am your NABH guide. In today's session, I will explain MOM.1 in such a way that you can implement it in your hospital, you can train your staff, and you can confidently face NABH assessors. We will cover each objective element in detail, practical examples, common non-conformities, and how to ensure 100% compliance. So let's begin. Written guidance. The first requirement is the backbone of MOM.1. NABH clearly says, medication management must be guided by written policies and procedures. Now understand this carefully. Medication management is not just giving a tablet to a patient, it is a complete life cycle starting from drug selection, formulary, procurement, storage, prescription, dispensing, administration, monitoring. If even one step is weak, the entire system becomes unsafe. What should your system include? Formulary system, approved list of drugs, controlled addition, deletion, procurement system, vendor selection, quality checks, purchase process, storage system, temperature control, segregation, LUSA, high-risk drugs, expiry tracking. Prescription system, standard prescription format, avoid abbreviations, dispensing system, double check mechanism, labeling, administration system, right patient, right drug, right dose, right route, right time. Monitoring system, ADR tracking, drug effectiveness. Critical requirement, all these activities must be supervised by a qualified pharmacist. Important audit point, this system should not be limited to pharmacy only. It must cover ICU, OT, wards, emergency, basically, entire hospital. Mandatory document. You must have a medication management manual. This is one of the first documents assessors will ask for. Multidisciplinary committee. Now comes governance. Medication safety cannot be handled by one department. It requires collaboration. Who should be in the committee? Doctors, medicine, surgery, pediatrics, etc. Pharmacist, nursing staff, quality team, administration, medication safety officer. What does this committee actually do? Not just meetings, it drives the system. Develop medication policies, update formulary, analyze medication errors, review ADRs, improve patient safety. Meeting requirement, minimum once in 3 months. Documentation, minutes of meeting, MOM, must include attendance, agenda, discussion points, action plan, responsibility assigned, timeline. Assessors don't just see MOM, they check action taken on previous MOM, system review. Now comes continuous improvement. Healthcare is dynamic. So your medication system must also evolve. What should be reviewed? Medication errors, ADRs, high-risk medications, patient safety incidents, rational drug use. Annual requirement. Complete system review must be done at least once a year. Medication safety officer must be designated, can be patient safety officer. Role, collect data, analyze trends, suggest improvements. Pharmacy closed, stock out. Let's talk about real-life problems. What happens if pharmacy is closed? Drug is out of stock. Most hospitals fail here. Common reality. Staff start calling vendors, no defined process, delay in treatment. NABH requirement. SOP for emergency drug procurement. SOP for stockout management. Best practice. 24/7 pharmacy. Emergency drug list in wards. Backup vendor system. Communication system. This is one of the most underestimated areas, but one of the most critical. What must be communicated? Drug shortages, drug recalls, within 24 hours, serious ADRs, medication-related incidents. Who is responsible? Pharmacy in charge. Documentation required. Communication logs, emails, circulars, WhatsApp alerts. With record, many hospitals communicate verbally, but do not document. This leads to NC. Common non-conformities. Now I will tell you what assessors commonly catch. No medication management manual, manual incomplete, committee exists only on paper, no MOM records, ADR, medication error data not analyzed, no defined medication safety officer, no SOP for stock out, staff unaware of processes, communication not documented. How to comply? Now the most important part, compliance. Step 1, build strong documentation. Medication manual, SOPs for all stages. Step 2, train staff, doctors, nurses, pharmacists, conduct regular training and competency checks. Step 3, activate committee, schedule meetings, track action points. Step 4, data monitoring system, maintain registers for ADR, medication errors, do RCA and CAPA. Step 5, emergency preparedness, SOP for night pharmacy, emergency drug kits. Step 6, communication system, define process, document everything. Step 7, internal audits, monthly audits, gap analysis. If you remember only one thing from today's session, MOM.1 is not about pharmacy, it is about patient safety system design, standardization, teamwork, monitoring, communication. If you are preparing for NABH, do not treat MOM.1 as documentation work. Treat it as a life-saving system. Remember, a safe hospital is not the one that has fewer errors, but the one that has a strong system to prevent and detect them. In the next video of this NABH training series, we will discuss organization develops, updates and implements a hospital formulary. If you want to learn NABH standards step by step, then video को like करें, channel को subscribe करें, notification bell on करें, so you never miss upcoming NABH training videos. Medi Quality Partners, your trusted NABH guide. Thank you for watching.